Assalamu alaikum. Inshallah, our first speaker will be and he will be discussing the latest research publications, data publications that we have. So we'd like to go ahead and welcome him on the stage, and inshallah we will finish this as soon as possible. Thank you.
Is it working?
Yes.
Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. I will be doing a brief data review about the thyroid-related publications in the Middle East, and then we'll gloss over some of the studies that has been done. Okay. If you have the PowerPoint on, please. Okay. Thank you. As you all know, not all studies are equal. There's a hierarchy to scientific evidence, and as you all know, again, the stronger the evidence is, the more difficult, the more time-consuming, more expensive, more manpower it needs. So studies usually start at case reports, case series, then go into animal trials and lab studies, cross-sectional studies, case control studies, and finally, cohort and randomized controlled trials. Now, as a single study, the randomized controlled trials are the strongest scientific evidence a single study can present. Although meta-analysis and systematic reviews are stronger evidence, but they are usually relatively easier to do because you're not dealing with patients or hospitals, you're actually dealing with already published studies. So theoretically, a single person, if he has the expertise, can do a systematic review and meta-analysis at home with a laptop and internet alone. Okay? For this reason, we are going to focus on these three types of studies: cohort studies, randomized controlled trials, systematic review, and meta-analysis. Through extensive research in the Google Scholar, we tried to find every single study that has been done on thyroid gland in the past year and a half, starting from January 1st of 2023, up till now. Okay? We focused on these because they have the most value and the most significance. At the same time, as you all know again, that below cohort studies, you can only draw conclusions about correlations and relationships. You cannot establish a cause and effect. The scientific evidence is not strong enough to allow you to say this is caused by this. However, from cohort studies and upward, you can actually draw a cause and effect conclusion. You can say, I believe this is caused by this according to my study, especially in prospective longitudinal cohort studies or all randomized controlled trials, assuming they have a high quality. And even systematic reviews and meta-analysis that includes cohort studies or randomized controlled trials have a stronger value than those that involve, say, case control studies or cross-sectional studies. Okay. And then I'll show you a table. Okay. This is where we came from. Now, I do remind everyone that this is approximation. We did our best to find every study, but it's possible we missed 1, 2, or 3. We combined many keywords. Anything contains thyroid, anything contains cohort or contains controlled clinical trials, and we went through hundreds of pages and hundreds of studies to find these numbers. Now, since the start of 2023, we had 245 studies, cohort studies in the rest of the world, and the Middle East had done 17. So total 262. And randomized control trials, 47 in the rest of the world, and Middle East had 10, which is quite significant, if you ask me. So total 57. And systematic reviews and meta-analysis, 284 in the rest of the world, 28 in the Middle East. Okay. And as you know, again, systematic reviews, they go about studying all the studies that has been done on a particular object, and they summarize the results. The meta-analysis goes a step further. it takes the data out of these studies and does his own analysis. So systematic reviews only summarizes what has been done and reviews it, while meta-analysis, I will take your data, your patients, and I'll do my own analysis and come to my own conclusion. Okay. This is the distribution of the Middle East studies according to country. I remind you all again, if a country in the Middle East is not seen here, is because we did not find a study coming from that country. It is possible we missed it, but this is what we found. Now, Iran takes the lead for all the studies. Core study 3, randomized control trials 5, and systematic reviews and meta-analysis 19. Followed by Turkey with just 8 core studies, and then 1 by 2. Egypt done 3 randomized control trials, and so on, if you take a moment to look at it. Okay. So that's out of the way. This is the studies we have. We're going to gloss over some of them, just to discuss and to see what we have done. Okay. Our first study is a randomized control trial. It's done in Egypt. It's about thyroid eye disease. They took 18 patients who had thyroid eye disease, significant one, and they did periocular injection of methotrexate or triamcinolone, okay, and then compared the results. There was a significant improvement. The clinical score reduced from 5.2 to 0.9, okay, and the mean proptosis decreased by 1 million. So they come to the conclusions, both are effective for the treatment of thyroid eye disease, and they can be safe as a first treatment or alternative treatment to thyroid disease. Okay. Our next study is also about thyroid eye disease, specifically about optic nerve compression. It is done in United Arab Emirates. They used tocilizumab to see if it had any effect on optic nerve compression. They took 30 patients who had unilateral bilateral thyroid disease. And after the treatment, they found the visual acuity improved from 0.5 to 0.9. The clinical activity score improved from 7.9 to 5 and less. Okay? And the proptosis increased by 3 millimeter by average. And the immunoglobulin also decreased. Initially, variation between all the patients, but all of them decreased to a significant result. And they conclude that tocilizumab is also a good alternative to a first approach or alternative to a second approach. Okay. This is a randomized controlled trial done in Iran. It's about Zataria multiflora boys, which is basically thyme or zatar, and its protective effect on patients who are undergoing radioactive iodine ablation. Protective effect on salivary glands. So they had 24 patients, 11 in one group and 13 in the other group. 3 times per week, they gave them 20 drops of oral oil of Zataria multiflora boys, 1 week before the radioiodine therapy and continuing up to 3 weeks after the radioiodine therapy. Okay? And they found that the case group that received the oil actually had a significant improvement in the function of salivary gland post-radioiodine ablation therapy. The parotid uptake index was significantly better, and the parotid ejection fraction was also significantly better. So they conclude that it has a protective effect on salivary glands for patients undergoing ray ablation. This is another study, which also done in Iran. It's about the effects of radioiodine therapy on fertility in males. Okay, so they had 18 men, 2 groups. 8 men received 13 millicurie of radioiodine, while 10 men received 150. Okay, they had a baseline value of a number of tests: follicular stimulating hormone, luteinizing hormone, testosterone, and sperm analysis. 3 weeks before the radioiodine, 3 months after the radioiodine, and then 12 months. And they compared the results. And they found that even a low dose of radioactive iodine can actually affect spermatogenesis, although the effect is not permanent, usually normalizes by 12 months. So they found there is a trending increase in follicular stimulating hormone and luteinizing hormone. However, no significant change on testosterone. The sperm count was what was affected in the spermatogenesis. So they recommend that patients should be consulted about this matter, at the possibility of this happening. This is a randomized control trial it's done in Egypt. Okay, it's about the effect of training on hypothyroid women who are taking thyroxine. They had 60 women and arranged into 4 groups. One group did not do any exercise. One group did only aerobic exercise. One group did resistance exercise, and one group did combined. Okay, the participants 3 days per week for 12 weeks had these exercises, and they came to a number of conclusions following them. They found that all exercise groups had a significant improvement in T4 levels, lipid profile, and physical related quality of life. However, only the combined group that did both resistance and aerobic training could improve significantly in TSH. Okay? So they recommend exercise in women who are taking thyroxine. Okay. This is a study done in Saudi Arabia. Okay? It's about a group of patients who are subclinical hypothyroid. At the same time, they are deficient in vitamin D. They wanted to see the effect of replacing the vitamin D on the subclinical hypo. Okay? Especially the autoimmunity and the thyroid function. They had 84 subjects, put it in 2 groups. One group took 50,000 international units of vitamin D weekly, and one group only took 5. Okay? They had a baseline investigation followed by 3 months and 6 months. After 3 and 6 months, when they concluded the case group, those who took the higher dose of vitamin D had actually a replacement of vitamin D. It was sufficiently improved the level. And they found there is a significant decrease in thyroid peroxidase antibodies and anti-thyroglobulin antibodies. So they concluded with no significant change in FT4 and FT3. Okay? But there is a significant decrease in TSH. So they believe that when you have a cyclemic hypo and thyroid and vitamin D deficiency, if you actually replace the vitamin D to a proper level, there will be decrease in the autoantibodies, and there will be a significant improvement in the TSH as well. Okay. This is a cohort study, our first cohort study. It was also done in Saudi Arabia. It's about the value of antibodies with regard to malignancy, its relationship. Okay? They had 473 patients, okay? And they studied their anti-thyroglobulin and thyroid peroxidase, and then they went on to the patient to see how much of them will turn out to be cancer. And they found out that there is a positive thyroid, there's a positive relation between thyroid antibodies and malignancy. So one study proved that if you can decrease the autoantibody by vitamin D, and one study said that there is a relation between antibodies and malignancy. Statistically significant relationship, that's what it means. This is a study, it's done in Turkey. The study is about the cutoff value of TSH in pregnant women in the first trimester. They wanted to challenge this, or just validate it actually. So the cutoff value was actually 2.5. Okay, so they had a number of patients, and they put them in 2 groups. One of them had a TSH less than 2.5, and one of them had a TSH more than 2.5. And it was a prospective study that they followed them, just observation. And they found the group of patients, which were about 100 patients in each group, they found that the group who had more than 2.5 TSH had a higher rate of miscarriage. This is the finding, especially if more than 2.5 and anti-TPO positive. This is the most significant group that had a higher risk of miscarriages among the patients who were more than 2.5. So they come to the conclusion that 2.5 is a proper line to consider it as a TSH, as a cutoff value for screening women in the first trimester about hypothyroidism. Okay. This is our first systematic review and meta-analysis. They wanted to find the relationship between PCOS, polycystic ovarian syndrome, and autoimmune thyroid conditions. Okay? There were 18 studies included. As I said, that systematic review takes all the studies and takes the data. There were 18 observational studies with 3,657 participants between cases and control groups. And they found that there is a very significant relationship between polycystic ovarian syndrome and the presence of autoimmune antibodies, and the presence of elevated TSH, and the presence of ATTPO and NTTG. So there's a positive correlation between this syndrome and all of them in thyroid. So basically it means that the control groups who did not have a PCOS did not have these elevated parameters regarding the thyroid, while those patients who had the PCOS actually had all these elevated significantly statistically. That's what it means. Okay. This was done at the time of the COVID-19. They wanted to find prevalence of thyroid problems in patients who are registered as having this COVID-19. In their study, this was done in Iran again, 8 articles and 1,654 participants, and they found that 26% of patients who were diagnosed in COVID had a non-thyroidal illness, and 10% had thyrotoxicosis. These were the most significant results of their systematic review and analysis. Okay. This is relatively new. It's a systematic review analysis and is done in Iran again. This is about metabolite signature of the thyroid nodules. They wanted to see if there's a difference in the metabolites between the thyroid tissue, benign nodule, and malignant nodule. Okay, so they did a systematic review and meta-analysis. 12 studies were included, and they found that especially, there are other findings, but this is the most important, that in malignant thyroid nodules, lactate and alanine were increased, while in malignant thyroid nodules, myoinositol, sialoinositol, citrate choline, and phosphocholine were decreased. Especially lactate, alanine, and citrate were statistically significantly different from benign nodules. So this is a new approach to diagnosing cancer in thyroid. Okay. This is a systematic review and a meta-analysis about the connection between obesity and thyroid cancer. Okay. And this study was done in Iran again. 25 studies were eligible. Okay. And they found there is a robust positive association between adiposity and thyroid cancer. It's a simple finding, but significant one, that there is quite a positive relationship between obesity and cancer. So obese people are more likely to have a cancer in the thyroid gland. Okay. This is also new. Trends in AI-powered classification of the thyroid neoplasm based on histopathology images. This goes in the realm of histopathology, and it's about how well can the AI diagnose slides, basically. Okay, so they did a systematic review and a meta-analysis, just a systematic review, 11 studies were included, and they found in the studies that the accuracy range of the AI to diagnose, to provide a proper diagnosis, ranged from 77% to 100%.
2 minutes.
With most studies, over 90%. They find that deep learning is effective and it will improve with time. Okay. Effect of Ramadan fasting on thyroid function. These patients who are hypothyroid and taking levothyroxine, what happens to their TSH when Ramadan comes? This is the systematic review and a meta-analysis. The studies, 14 studies, 3 randomized control trials, and 11 observational studies, 1,661 patients. And they found that there's a significant increase in TSH in patients who go into Ramadan before their pre-Ramadan values. However, the number of people who go above their reference range is not significant. But there's so it can go from 0.5 to 1 to 1.5, but not over the reference range. I also found there is no significance between the timing of thyroxine taken. Is it after iftar? They take a date and take the thyroxine and wait half an hour, or is it 3 hours after iftar or pre-suhoor? They did not find a difference between these timing for taking thyroxine in Ramadan. All of them showed a significant increase in TSH, but not over the reference range. Okay. Carbon nanoparticles is a new material. It's not new actually, but it's available. It's used during thyroid surgery. It's actually injected into the thyroid gland. It can go through lymphatic tissue, but not the vessels. It actually helps to increase the number of lymph nodes removed during dissection, and also helps prevent parathyroid gland accidentally removed. So they found that the using of carbon nanoparticles decreases the risk of thyroid gland removal by accident by 84%, and the number of lymph nodes improved significantly, improved statistically. Okay. This is our last slide, and it's our last systematic review meta-analysis. It is not run again. It's about the prevalence of sexual dysfunction in patients who have a thyroid problem. And the result is interesting. 17 studies with 501 patients. They found that patients who have a thyroid grave disease had actual 51.5% of sexual dysfunction, while patients of hyperthyroid have 59 and 41 in 41 hypothyroidism and 59 hypothyroidism. So the conclusion is that this is significant, and please consult your patients when they have any of these problems. And thank you.
Thank you, Dr. Karzan. He did a really wonderful presentation, eye-opening on the ideas of research in the Middle East. Our next panel will be led by the chairman, Dr. Mohammed Al-Qudaa. Inshallah, he will come up here and we'll have an open discussion about how we can improve thyroid in the Middle East. And then there'll be a series of subtopics, inshallah. Doctor, the stage is yours.
بسم الله الرحمن الرحيم. أسعد الله صباحكم الخير. Good morning all. And I will start by thanking Dr. Abdul Wahid and the team for this excellent summit so far, and for the hospitality and for the nice food that we have yesterday. Everything was fine, and everything is positive toward going to the next step after this summit. And having a summit about the thyroid disease is an excellent idea, especially in the Middle East. And we need to think all together what is next. I think that advancing in thyroid health is something that we can do. We are having specialties from all disciplines in medicine. We are having radiology, pathology, surgery, medicine, pharmacology. We are having everything now in this room. And thinking about next step is something excellent, and we need to do it together. I will give an example about what we are doing in lung cancer. In lung cancer, we are having a group led by one of my colleagues called Dr. Tahir Abu Hijle. He did a lung cancer interest group. And from all countries in the Middle East, and doctors from the Middle East, outside Middle East, we are discussing cases every day. And we are improving our understanding. So the suggestion about this panel, as we discussed, is to think together about many ideas that we might develop. Now, such a summit might end up by having extra ideas about education and awareness regarding thyroid, research and publication, clinical practice guidelines. We discussed many practice guidelines yesterday. Some of them were very new for me. Actually, we need to develop this, and we need to work more about this. Advocacy and policy influence, professional development, patient support and resources, collaboration and networking, which is an excellent thing that we can do, publications and journals, quality assurance, and international collaboration. All of these are ideas that we can put in front of you, and we need more from you, actually. So the suggestion is that each table have like a mark about the specialty. So each people from each specialty can sit together for 20 minutes. We might suggest, Dr. Abdul Wahid, 20 minutes. For 20 minutes, each team will discuss what ideas they have to improve the outcomes of this summit. And after 20 minutes from each table or each specialty, we'll have a representative to present the ideas from them, and we will take all the conclusions and the ideas and discuss it together after. Okay, so 20 minutes from now, and we will receive comments from each specialty or each table about the next step.
Şeyini bak o koşanlardan. نه کاکات میتو کاتش میودو.
خێزانەکە زۆر دڵخۆش بوون بە بوونی مناڵەکەیان.
Bismillah ar-Rahman ar-Rahim. So I hope we had like 30 minutes of discussions about how we can improve the outcomes of this summit and how we can continue working and achieving excellent activities and excellent outcomes through such collaboration together. I will start asking each specialty or each table. We have specialties that were in many tables. I will ask each table to present the ideas that they discussed over the last 30 minutes. So we will start by surgery. This table, please. Yeah, have. So each table or each specialty can present their ideas within 2 minutes, 3 minutes. We will take all the comments, add them to the list, and discuss them after. We will also put a QR code by the end of this session. Anyone who is having any idea, they can submit it immediately through the QR code and we will follow it up. So, Doctor, please start, and we have 2 minutes to listen to your ideas.
Thank you very much. Benawi Khwa.
Voice.
Bismillah ar-Rahman ar-Rahim. طبعاً سباس بوهمولايك. This is the summary of our group discussion on surgery. Probably our colleagues have some additional to it. To improve thyroid surgery practice, number one is training and preparing a good surgeon, competent and for this job. This is very important. And also involvement of technology, advancement in technology and artificial intelligence, practicing involvement in this important part of surgery, including, of course, the nerve stimulator, the parathyroid identification, the molecular biology, the frozen section to be available when you are dealing with a nodule with the help of pathologists to be handy. يعني يملا في فيركاري بابا سينكين حول معنا دوسي جارو دواي بوبا قرص بارجراني بس pathology. So the guideline is important. We should have a national, international guidelines for thyroid surgery to be practiced. And the journals, there is a beautiful journal, American Journal of Thyroid Surgery, and there is European Journal of Thyroid. And by the way, the impact factor of American last 2024 now is over 6.5 points, 6.5, while the European is 4.6, something like that. So these are very important. We research, we should encourage the research on the subject, on the local area, on the national or regional area. And we should have a special society يعني for thyroid surgery, local or national, or at least in the Middle East, to gather the important personnel working in this part. And also this summit, these are very good beginning. And I am very thankful for those who start this point. This is the beginning, this is not the end. It should be regularized, it should be continuous. And for next when and where to do. And I want to add, this is from the committee, I want to add few points from my experience. We are triple, God, us, and people. And one of the most important people to us is the patient. So all our aims is for the benefit, for the best interest of the patient. But remember, we should remember there is God above it, and there is people watching. مجلات أما صحافة وترميشك اللي كان بقاميش يا خود زاني. So be careful, you should train very well. People, we are always we are student. We are learning more and more from each others. We start as a novice. يعني هسه سرتا ساوي الكين. But then later on we become a beginner, advanced beginner, then become a competent. Most of our people, doctors, teachers, they are competent with their job, but this is not sufficient. We should go advanced behind. Until the competent, you need a guideline. You should go and restrict to what's the instruction is mentioned in textbook, in magazine, everywhere. But after that, you should advance yourself to be proficient. Professionalism is very advanced stage, and not everyone reach professionalism. After that, you reach a level of expert. Expert are those people who do little or minimal or nil mistake in their job. They sometimes, we discussed with the group, they are go beyond the guidelines. They are themselves the guidelines. They decide at the situation immediately, instantaneously to correct any problem that occur at that time. So we need expert in thyroid surgery. Expert in thyroid surgery to direct the young junior doctors, to direct them for further advancement to reach the result until يعني شلون أبي خليفة بخوان دانيان at that part, because they are expert is not the end. Their message is to make people expert. And thank you very much.
So you are, doctor, suggesting that implementing artificial intelligence in teaching our students and junior doctors, and having like a journal for regional journal to follow up the work, and to have like a society to gather this work and to follow it up.
And this conference should be continued.
Yes, definitely.
And we need expert people.
Expert people. Okay.
Okay, to respect their idea, their experience, and they are always our teachers.
Okay.
In every part, not only surgery, in every way.
Every part.
And you see that in some cities, there are few teachers. They are expert in their teaching. We mention them all the ways throughout our life.
Okay. Thank you. Thank you very much. Thank you. Medicine, endocrinology. We will go back to surgery. Between each surgery and surgery, we have a specialty. Yeah.
Assalamu alaikum. I was sent up here, so if I say anything wrong, you know, they say, don't kill the messenger. The ideas that we came, I think generally will be mostly overlapping ideas, of course, because you can only have so many new ideas. One of them that we were thinking was obviously everything through a multidisciplinary approach. So every person, in every program in every country should have at least an MDT, surrounding themselves with valuable people who are according to guideline, who are up to date, you know, tall, handsome guys who are smart and are good at what they do. So they have an expert opinion all the time. For example, pathologists and radiologists and surgeons, and then also endocrinologists. And endocrinology is also very important, so listen to those guys, they're very smart. And then also implementing a quality assurance program. So quality assurance programs like to monitor and evaluate the outcomes of thyroid surgery. So for example, like the patient's leaving the office of the surgeon and then also being followed up by medicine, to know what was done for the patient, if there are any remnants, if there's any type of like, was it a cancerous tumor, or how to follow up the patient in the future, and then also ensuring patient safety. Patient education is also like the third point. So patient education is important regarding preoperative and postoperative care, and then also informing them so that they make like good decisions for themselves, to see that they have options. So there are multiple surgeons here. Alhamdulillah, we have a lot of very, very smart surgeons and everything. So they can pick from which one is the best guideline. I think the previous speaker mentioned sometimes the patient has too many options and they don't know exactly what to do or what's best for them, because one surgeon will say, okay, this is my guideline, I will follow this guideline, and another surgeon will say, no, this is just a benign nodule, just needs follow-up. So the patient's kind of confused. That's also something to consider. Regarding research and innovation, I guess will be our last point. Just also have funding to research. Funding is very important. Like departments, every hospital needs a research department, so a dedicated research department. And also, the last point was surgical. Trying new things, like trying to implement new techniques in your clinic, or in your procedure, always trying to work out of your comfort zone to learn something new, some new approach, or the latest approach to a thyroid surgery. So the old technique is not necessarily the best technique because you're familiar, but maybe something else also is available that can be used. So I think that was our only points. Thank you.
So thank you. Regarding patient awareness, I think that having a platform for all thyroid patients, regardless of the disease, having a platform for thyroid diseases so patients can safely navigate through and know what are the options for their diseases is something excellent that will be of excellent value for patients so they can be aware about the options that they will have.
Yes.
Okay, thank you. Thank you very much. Going back to surgery. Pathology.
Assalamu alaikum. My name is Dr. Sadoun. After discussing on our table with our colleagues, actually we reached to many things, and my teacher, Professor Dr. Farouk, presents some information about how we progress this association. Actually, first of all, this association is, we have to insist on this association, which is very important, like other association in the world. And through this association, we can progress our information, and also we have to be a better communication and make chances for the training of the membership. And through this association, we have to give actually certificate after the training, and we exchange new information through new surgical techniques. And also we have to, through this association, we do international MDT and to discuss challenging cases. This would, I mean, collaborating and through networking and committing for awarding those who want to get a certificate in the thyroid disease. Also, through this association, we have to put a guideline, actually. Guideline is very important, especially to avoid non-indicated surgery. We know there are many non-indicated surgery for the thyroid, and after that, the patient may suffer actually from many complications. And also we need this to repeat through annual meeting. We need annual meeting, even if it is not in our country or our city, and through this association to help the members to share new information, to also can go to any country and to make it easy for the membership. Also, we need more actually information regarding the new guidelines through the surgical technique or any information about the thyroid through the emailing when we become a membership. Thank you very much.
Thank you. Thank you very much. Well, another supporter for the society or association for the thyroid, which is something that I think we need to think about it, because it will be like an umbrella for every activity or every suggestion that you mentioned. Thank you very much. Now for pathology table. Okay. We need diagnostic suggestions.
Diagnostic suggestions. Assalamu alaikum. I'm Dr. Ram, a pathologist at the Smart Health Tower. This is a summary of the points that I discussed with my senior Dr. Ari, who's the lead pathologist here. I think one of the most important things is to maintain the connection and prevent a significant time lapse between this summit and the next meeting, because as time passes, everyone will forget about the points that were discussed, the importance of the meeting. So I think it's imperative to decide on what is next. whether it's just the next summit, or whether we need to set up an association or a society. And I think it is actually important to go beyond a summit if we want to develop local guidelines. It's difficult to develop anything further from a summit alone. So the first thing that we need to focus on is what to do next. Is it just the next summit, or do we need to set up the society or the association from now? In addition to that, I think it's important to set up a sort of research group or a medium in which we can collect data from these different member countries of this event, so that we can do multi-country papers. Because at the moment, it's usually limited to a single hospital or institution, or at the most to a single city. But if we develop this connection, then we can actually write much better, more powerful papers. So the first thing is actually collecting data from different centers in different countries to do combined research. The second thing is to establish a platform for sharing cases in the diagnostics department. So that includes both radiology and pathology mainly. If we have interesting cases to share, if we want to take opinions of other ones, I think Dr. Aras is disagreeing with me, but I think it's of benefit, especially for pathology. Sometimes we want to take the opinion of another pathologist elsewhere, or we want to share an interesting case. I think this will be a good medium for that. And this medium, this platform can actually also make it easy to share lectures. Say somebody in another country, which is a part of this summit, is delivering an interesting lecture related to thyroid. And why not make it available on a platform that the other member countries can also participate, and they can ask questions or give their own comments. So we need a platform for sharing cases, taking opinions. We need a platform for sharing lectures and seminars. And then the international MDT, this has already been proposed and discussed by Dr. Abdulwahid, and we've actually had a few of those. We already have multiple MDTs at the Smart Health Tower on a weekly basis. So if we can make it a standard practice that we allow access from other countries, from other areas online, and people from the other countries can do the same. So if they have their own MDT, they can provide a platform for live access from other countries so that surgeons or pathologists or radiologists or endocrinologists can also participate and give their opinions. So international MDTs. Now the next thing, as I said, we need a society or an association to develop guidelines, and the guidelines have to be tailored to what is available in that specific region. Because, and actually the thing that I remember related to this point is the issue of breast FNA. We don't do breast FNA because we don't need to, because core biopsies are available. It used to be done widely, and there's actually good guidelines for reading breast FNAs. But when you read the guideline, you see that it's focused on those areas in which the availability of core biopsies is limited. So it is true, in some areas it may cost more, people may not afford it, or it may not be available. So we need something that is accessible, that makes sense for our locality, and that is why we need localized guidelines, not international guidelines which are based on treatment modalities or diagnostic modalities that are not available. It would be irrelevant for us. So in summary, we need to develop a society or association to develop the guidelines. We need a platform for sharing cases, for sharing lectures, and the international MDT that we mentioned. And the last thing, and also of course the research group, the last thing is attachment programs. I think it would be worthwhile both for junior doctors, for new seniors, or even for experienced seniors. If say I want to go to Jordan and have an attachment program for 2 weeks to see how they manage cases there, how they sign out their cases. I think it would be of value, especially for new doctors. If we develop this sort of connection, this sort of association among us, I think it would be of value. And thank you.
Thank you. Great. Thank you very much. We will go back to surgeons now. This table. And I will ask if there is someone to represent suggestions from public health, Dr. Abdul Fattah after, if there is something from nutrition background to submit something and suggest, we'll go. surgery, then other, surgery, other.
All right. What's your name, doctor? Sorry. Yeah, yeah. Huh? Ra, yeah. So from our part, it's just copy paste what Dr. Rawa have said. Thank you so much. No, I'm joking. Anyways, you guys already have mentioned most of the things. We already know where we start. We know exactly how to move forward. A few points from our table. Basically, we need to be pursuing research. As we know, research, it's an extra work, especially for a busy clinician. It's an extra work. And what we found is if you have somebody, coordinator, whose job is basically just to do the research, it will make it much easier for us. Yeah. So what we suggested is if we have somebody like a coordinator to basically establish a database for all of us, which is HIPAA compliant, where we can put all our data, and then within 2-3 years, we're going to have thousands of cases. We can interrogate those database, and we can do research representing our community, our countries, our Middle East. So this is, I think we should start this. The other thing is, the other point we discuss is training and innovation. We need to make sure we are training our younger generation. We make sure like we innovate, try to push the borders with regarding to doing more complex cases or more innovative cases. Thirdly, what we lack here, especially we're behind in the world, public awareness and public education. Patient need to know that there is a thyroid surgeon. Patient needs to know if you need to do a surgery, you need to go to a high volume thyroid surgeon. Unfortunately, most of the patients would go to a general surgeon or to a surgeon who does not do a thyroid. So this should be part of the thing we need to be doing. Fourthly or lastly, this is an excellent meeting. In the future, before we leave, we should know where is the next meeting, what are we going, where, time. So we're going to meet today, and if we don't take the initiative or do something, we're probably going to meet again in 3-4 years, which is not the ideal. So ideally, in this meeting, or the next meeting, we should know where we're going to go, where is the meeting, what's the agenda, and move forward. And with this, I would conclude. Thank you guys so much. Okay.
Well, final point was where is and when is the next meeting. I hope that Dr. Abdul Wahid will accept our invitation, me and Dr. Ali Al-Abous, to make the second summit next year in Amman, inshallah, if this is applicable from your side. We are more than happy to do this. Okay. And regarding the public health point, I want to hear from Dr. Abdul Fattah, because having something to the public is one of the main jobs that we need to do in this concept. Dr. Abdul Fattah.
Bismillah. As the most difficult thing, almost always, we as a public health specialist have a challenge with the medical doctors, with the surgeons, and something like that. That's why I'm alone here. I'm representative of my group, which is only me. So I want to explain important new strategy for fighting any cancer problem related to any organ. Now we have what is known as a cancer control strategy. In cancer control strategy, we need a strategy. We have 5 most important strategy. The first one, we need the advocacy and the governance for this issue. The second one, we need the primary prevention. The third one, we need a secondary prevention. The fourth one, we need a rehabilitation. And the last one, we need a system for the controlling of this problem. For dealing with any health problem, we have 4 important levels of the intervention. Level number 1, which is a primordial prevention. For example, for the problem like thyroid cancer, regarding the primordial prevention, we should know what is the link between the cancer and the thyroid problem and the gene. That's why the gene intervention known as the primordial level of the prevention. The second level of the prevention, which is the primary. For example, the intervention of the primary intervention for the thyroid problem, we have patient awareness. We have, is there a possibility in the future, the role of the vaccination. So patient awareness, patient education, and vaccine under the umbrella of the primary level of the intervention or prevention. The most important level is the level of the secondary prevention. In secondary prevention, we have a screening program, we have the early diagnosis, we have the early treatment. That's why I say we can do a lot in this level for the thyroid problem. And finally, for those people that complicated with the thyroid problem, we need a rehabilitation. Rehabilitation physically, rehabilitation socially, rehabilitation mentally, and sometimes we need the rehabilitation economically. That's why if we need to do something for the thyroid, we should have a plan at the all level of the prevention, not just the treatment and the diagnosis. And actually in the Middle East country, especially for the cancer, we have a big challenge. Almost always we deal with the diagnosis and treatment. And you know, up to date say that 1/3 of all cancer can be totally prevented. 1/3 can be early screened and early diagnosed and well treated. And 1/3 can be rehabilitated very well. That's why we should focus on all levels, not just on the level of the diagnosis and the level of the treatment. If we think to have something like the association for the thyroid at the level of the Middle East, we should also cover the epidemiological aspect. Without the epidemiological study, we cannot take any correct decision. We should have a well-organized epidemiological study to know what are the factors behind the thyroid problem in our society. This is a task of the epidemiology. That's why the role of the epidemiology is very, very important. And finally, we need a team. Team is the abbreviation of the together, everyone achieve more. We need the umbrella, we need the organization to cover all of the aspects of the thyroid health, because there's a big difference between the medicine and the health. Health is more broader than the medicine. Health is deal with every aspect of the life. And thank you.
Thank you. Well, going back to surgery. Yeah, please. Then radiology.
السلام عليكم. دكتور حسين هادي الشحماني, Consultant General Surgeon in Baghdad Teaching Hospital. Dr. Hussein Hadi, Consultant General Surgeon in Baghdad Teaching Hospital. In 2008, I was in South Korea and I was training with Professor Choi, who is a thyroid and breast surgeon. And he asked me, because I work in the biggest hospital in the Iraq teaching, he said, you follow any guidelines in your hospital? At the time, I was ashamed because we didn't have any guidelines. We just hear it and read it in the books. He said, come, and he opened the desk. He said that we follow either American or Canadian or British Association guidelines. And in their hospital, there's British Association guidelines, and he said read the first phrase in these guidelines, they wrote it that these guidelines based on reviewing of hundreds of research, and there is no single opinion in these guidelines. So, in our circumstances, to be honest, it is so difficult to put a guidelines as a guidelines, but to be started to put protocols for our work. From this summit, which is I glad and I pleasure to be present in this summit with this very experienced colleague. We have to establish Thyroid Association, and this Thyroid Association, we can cooperate in the future in improving especially the randomized work in the thyroid disease nowadays. So to establish the association, and after this to assist to the what we call thyroid clinic. On the same as the breast clinic, we have a breast clinic, so we have to put a thyroid clinic, because the thyroid cancer, we know, it is the second most common cancer, come after the breast, and they suspect in the future to be the first even on the breast cancer. On this clinic, we have to make definition and job description for each member. First of all, definition of thyroid surgeon. Who's thyroid surgeon? Not every surgeon he do 20 or 30 operation per year, and it's thyroid surgeon. To be definition, and in these guidelines they said that is there is specialist radiologist, specialist cytopathologist, just for thyroid, specialist for that, and to make a unique protocol for reported, put it report of ultrasound, report of radiology, report of cytopathology, and to be stopped to give recommendation in this report. Because after collecting data, we have to make an MDT decision, multidisciplinary decision. It is not our decision, not me as a surgeon, not as a nuclear, not a endocrinologist, and even the patient, he had to participate in our decision. Thank you very much, and we have to meet again. Thank you.
Thank you. Thank you very much. Now the first radiology table.
Assalamu alaikum. Welcome. Bakhair bin. I am happy to be here with my colleagues. A nice meeting. Most of my colleagues mentioned most of the point. After discussion with my colleague, the radiologist, we make agreement on these points. Of course, the first of all, we are all agree about this, the multidisciplinarity team. Working as a group is the most important thing. We are the radiologists, of course, the cornerstone in this group. We are making the diagnosis. We are the eyes of the surgeons. We are helps of the surgeons to see what are behind after that. I encourage my colleague and most of the doctors to go to the subspecialty. It is very important thing, specialty in the thyroid. This is very important point. The next point, making training and attachment and for all the specialty, especially the radiologist, and also encourage the minimal invasive intervention, or encourage the intervention radiologist in the thyroid. This is very important things. The next point, making a guidelines and stick to the guidelines, and also making communications between all groups, radiologists, pathologists, surgeons. And the next point, making a platform for research. This is very, very important thing. And at the end, as mentioned my colleague, making the next step after this meetings, making the next one, and at the end, thank you very much.
Going back to surgery, is there any surgery tables that did not? Yeah, please. ما في أعطيناهم ثاني option.
Good morning, everyone. I think most of the point has been mentioned by the other groups, but I would like to summarize the point that our surgeons that we agreed as a recommendations for the summit. First of all, we advise that there should be the formations of a Middle East Thyroid Society that involves all the specialties, including the surgeons, the endocrinologists, and the pathologists. And also there should be a connections with other associations like the European Thyroid Associations or the American Thyroid Associations. The second point, again, is that we advise for a seasonal online meeting that discuss the thyroid problems. And this discussion should be, again, between the different specialty, especially as you know that thyroid is common in our regions, thyroid problem in general. And the third point, again, we advise for establishing a new guidelines for the management of the thyroid disease. And the fourth point, again, we advise for establishing NDT and team working in the field of thyroid disease management. And also we recommend keeping online contact between the members of this summit so that we can discuss some problems regarding the thyroid disease through the WhatsApp or Telegram or a Viber grouping. And lastly, again, we advise for establishing a subspecialty in endocrine surgery, mainly on thyroid disease, in Arabic or Iraqi boards. Thank you very much.
Another group that is supporting the idea of establishment of a society or an association for the thyroid work group. Radiology, we are waiting for your comment.
Assalamu alaikum. My name is Dr. Adil Mahmoud. I'm from the consultant radiologist. Actually, I was not planning to participate, but I was pushed to. Anyhow, we have got thyroid system for diagnosis of thyroid lesion on the ultrasound. Sorry, just give me some time. Let me calm down. Okay, so the thyroid is a system set up in the USA. In the UK, I believe the people who are working there, they know they don't follow it strictly. And each NHS trust, they do have their own system for grading of thyroid lesion. And the place where I used to work in Scotland, they used to have U1 to U5. Feeling sorry.
What doctor is mentioning is that the Bethesda system is not even followed in all over the countries. So in UK, yeah.
Just give me some time to relax. Okay, so in Scotland they used to have U1 to U5. U1, which means normal thyroid. U5 means that's malignant. And we didn't follow the thyroid system. Anyhow, for thyroid is a system that's used globally, but not in the UK. Some places of the UK adopted it, but they did modification for it. So my opinion for the Middle East doctors to make their own thyroid system and modified it accordingly, which means that to put the terms and description that we need to understand, not the UK or the European understand it. Sometimes when I do put my report, the surgeon or the physician wouldn't understand what I mean by it. They do use to the thyroid 1, thyroid 2, but they don't know what do we mean by it. So if the summit make a plan, make a committee in the collaboration between the radiologist, surgeon, physician, pathologist to make their own thyroid modification and distribute it and strict to it. Although strict attachment or following the thyroid is not, as we say in Dog, it's not a harf of Quran, which means you can manipulate it easily. It is not haram or halal. So my plan or opinion is to make a modification for the thyroid. This is about the thyroid. One of the suggestions from the group, although I didn't agree with it, is to make an FNA for non-thyroid lesion, which means if there is a diffuse thyroid problem, to make an FNA for it. I don't know what's the scientific benefit, but the surgeon and physician and the pathologist might have an opinion on it. And thank you.
Thank you. Thank you very much. And this suggestion supports the idea of having a regional agreement or a regional description for the thyroid lesions. As Dr. mentioned, in UK, most of deaneries follow their own details or own description for thyroid lesion. So, Doctor?
Bain Tamash, good morning. My name is Dr. Aras. I come to thanks two gentlemen, one of them from Kuwait and you, sir. When he asked the question, where will be the next, and you answered, this is very good. This is what we want. Okay. From the beginning of this idea, we want this question. We want the answer of this question. When this gentleman asked, and I personally thank you, and you say it will be in Amman, this is make our decision to make such a communication is, thank you very much. I don't know to say more than this. Second, for radiology, we can improve radiology by this team in simply putting a group in WhatsApp, in any simple social media, so that, for example, sometime if I have a CT scan, I don't know what to do, I can send it to you within a minute or hour. You can look into it, and all the data will be. And this is the simplest way to make a communication. Second point, we need the help of histopathologist and surgeon. This is a family. This is a job of each part of it. We don't want to invade surgery. You don't want to invade radiology. You don't want to invade histopathology. Imagine someone has a board degree in radiology. He will do the radiology job better than you. For example, if you have a PhD degree in surgery. If you are a surgeon, you will do your job better than me if I have a PhD degree in radiology. This is the idea. Job description is the second point. And third one, we should have, for example, all the doctors who's now coming, they are from Jordan, Kuwait, and every other country. We can put a simple site to share information between each other.
Okay.
This will be the first. Yeah, thank you very much.
Thank you. Thank you very much. Doctor? We have another 20 minutes to discuss ideas. I think Dr. Abdul Wahid, 20 minutes? Yeah.
Okay. Thank you. I am Dr. Ashraf Abdurazak, consultant surgeon from Mosul. Okay. All of us now, we decide to do association of thyroid disease in the Middle East. So what is the plan? We think it is the plan to re-meet in a few months in multiple sites of these countries to meet a lot of peoples, a lot of doctors in these regions to take ideas, to then to do a plan and to put guideline for the thyroid in the Middle East. So I suggest after 2 months we re-meet in other city or other country, and after 2 months in other site and 2 country. And this group will enter in a special group in WhatsApp or like that, and it is first for Thyroid Association. So we can meet like in Mosul after 2 to 3 months, and in other place in Gulf City and like that. Thank you.
Thank you very much. Well, is there any table that will have suggestions? Yeah, please. And before that, is there anyone with a nutrition background that will have any suggestions to add? Nutrition. Thyroid and nutrition is a topic that needs to be discussed. No? Okay.
So, good morning, everyone. To start something from scratch is not easy. So, again, thanks to Professor Abdul Wahid to start this system. So I have 2 suggestions. The first suggestion is to establish subgroup. I mean, thyroid is the title, and then below the title should be subgroup like endocrine surgeon first, radiology, pathology, nuclear medicine, and then all these subspecialty together to submit the best thyroid service in the Middle East. So this is the first. Second, the sustainability is the most important. To start something is difficult, but the sustainability is the most difficult thing. So I suggest, as my colleague said, Dr. Salman, to establish the next, and also in between to discuss the most difficult case where we can submit, let's say, 5-star service in terms of thyroid. So this is my suggestion. Thank you very much.
Thank you. Thank you very much. Any other suggestions before we go to Dr. Ali Al-Abous, who is having another suggestion from surgery point of view? Okay, Dr. Ali.
Bismillah ar-Rahman ar-Rahim. I will not add anything new because our colleagues contribute very well in good suggestion, which will establish guidelines, because the guidelines, it's not good only for doctors, it is also good to protect any doctors who deal with any disease, because when he follows the guidelines, this is a main protection for him, especially from the medico-legal aspect. The other thing, it provides that the patient will deliver the best way of management, whether this is through diagnosis or pathology or even the medical and surgical aspect of dealing with this disease. I think the best way to do these things is to establish a society that will provide a permanent way to improve in the future any improvement in the science and apply it immediately so as to follow what the other part of words do for the good thing of best management. I want just to repeat some idea about suggestion regarding the surgery. Thyroid surgery, you know, the most important of it is the morbidity rather than mortality, and the most complications that not only the patient but also the doctors who deal with it, especially the surgeon, is to avoid complication, naming the vocal cord, recurrent laryngeal nerve injury, and the problem with the parathyroid and the hypocalcemia that may be permanent and or temporary. We noticed that the nerve stimulator is the best way to identify the nerve so as to avoid any dissection around the nerve in order to see it. Now by the nerve stimulator we can avoid these dissection and also avoid adhesion that make the future surgery very difficult and carries a hazard. And the next improvement in the management is the identification of the parathyroid gland. We know that there is a new way of identification called NIR, near infrared radiation, which detect the fluorescent radiation from the parathyroid. This doesn't need any injection, and it is immediate and has many advantages. The first, to identify the parathyroid and avoid any injury to the parathyroid. The other thing that we know as a surgeon, sometimes when we do central dissection, that we may leave some tissue, maybe lymph node which has emits, because we are afraid that maybe this is parathyroid. Now, if we have this probe, which is immediate, so we can dissect any diseased parts without afraid that this is a parathyroid gland. Thank you.
Thank you. Thank you. Any other suggestions from anyone in the room? Okay. To conclude, دكتور تفضل. عمرك. هاي المايك إذا بدك.
Thank you very much. This is beyond suggestion, some suggestion and some comment. And thank you very much. You remind me for the nutrition. Thyroid is very important. Originally, in the basic college study, they said that we need iodine for the formation of thyroid hormone. This is not so. Trace element, selenium, zinc, vitamin D, and a lot of even amino acids, they are very essential for production. And thyroid, with all my respect to ladies here, is very delicious organ, like ladies. Just tell them, sit. 1 week or 1 month will be away from you. Thyroid gland is very easily damaged, even by palpation, by cold, by environment, by stress, by everything. So we should respect thyroid gland as it is the dynamo. It's a dynamic organ in our body. 2/3 of all the basic metabolic rate is underrun through the thyroid hormone. So we should remember that thyroid is very fundamental for life, and it is very essential. Nutrition is very important. Some foods, this need a special meeting probably. Foods that can activate or destroy the thyroid gland. Even I read a paper, some of this food which may damage the thyroid gland originally were toxic to insect and some animals, then detoxified by thyroid gland. There is a paper written on this subject. Foods that destroy the thyroid gland, they originally were toxic to animals or insects. Also, the viral, the immunity, all the body immunity and thyroid hormone. During the COVID-19 outbreak, they realized that thyroid people who attended or admitted to ICU or with grave prognosis, almost all of them, they have thyroid disorder, thyroid 6 syndrome, in the form of hypo or even hyper. So, and they found that those with high mortality, they have thyroid disorder. So definitely there is a correlation between the prognosis of COVID-19. And they found that a lot of things, the angiotensin converting enzyme type 2, which is the receptor for the COVID-19 virus, they found that they are available in thyroid follicular cell 4 times more than the alveoli of the lung.
Yes.
So these are a lot of advancement in thyroid physiology, in thyroid pathogenesis, in thyroid illness. The probiotics and the microbiotics in the body, in the intestine, in the large colon, we are destroying them by antibiotic haphazardly, which is used. These are very important for the nutrition and the state of. And there is a good correlation between autoimmune thyroid disease and colonic microbacteria. The bacteria is there. There are a lot of studies. We should think and revise all these articles for the future. So the microbia in the colon, the flora, they are very important, even for, say, thyroid, for, say, uterus, for, say, ovary. So this will interfere in the immunity circle in our body. So we need a lot of revision, and we should know that this is a very delicate, and vascularity of this organ, gram per gram, is more than other tissue.
Yes.
So any antigen will enter the circulation, will say hello to our thyroid. Thank you very much.
Thank you very much. Thank you. Any more suggestions? تفضل.
Good morning, everyone. Thank you very much for my invitation. Thank you for Dr. Abdelwahid for inviting me to this nice event. I'm Dr. Beckers. I'm a respiratory physician from London. I have my own practice. The topic you discussed is very interesting to me. What I do in my practice, as a private practice, I do a thyroid function test as a routine for all adults above age of 18 or above age of 16. And if there's any abnormality like hypothyroidism, I will treat in the community. If there's any kinds of Graves' disease or thyroid toxicosis, I start them on treatment and refer them to the local endocrinologist. This is about the endocrinology part of it. When it's coming to the thyroid nodule, there's a protocol about, on NICE guidelines, which is any lumps and bumps, any part of the body, we have to refer to the secondary care within 2 weeks referral. It's called 2WW. And this means that this patient will be seen within 10 working days by a specialist in the secondary care. So this is a basic thing I work on it. Now I have a couple of things to ask you very briefly, especially Dr. Abdelwahid. I would like to ask you if there's any public health awareness in this area regarding thyroid problems, number one. Number two, do you do any kind of screening for thyroid problems in the area, which is very important. One of my colleagues mentioned about a patient or public awareness, which is very, very important. Patient to palpate the thyroid, if there's any family history, if there's any history in the whole entire family about any kind of thyroid problem, to seek advice or to do some kind of blood test as a minimum. Okay. So this, as I understand, there's no primary care services in this area, which put the pressure more on the specialist. But there will be a good idea if you have got some kind of screening for the public to do at least TFT, TSH, basic blood tests for thyroid function test to early diagnose any kind of pathology in the thyroid gland. Okay. Thank you very much again.
Thank you. So you are asking about if there is any awareness and screening campaigns in this region. I hope someone from this, from Sulaimaniya can answer the question about any awareness or screening programs for thyroid diseases. Dr. Abdelwahid, the mic.
Thank you very much. We are all welcome here. For the screening program, we don't have a screen, but usually when the patient is discovered to have a MTC, medullary thyroid carcinoma, or PTC, we will advise all the other members of the family to come and do calcitonin and the ultrasound on the annual basis. This is for any patient who received radiotherapy for the breast cancer or for any other reason. We will, after 3 years, check the thyroid function test for hypothyroidism, and after 5 years we will check them for the nodularity, because you know that is occur after 5 years of the radiation. And we have a awareness, we have a site, we have a page, we have an application, we have awareness for the public health, and everyone can enter. And we have a series of videos, name it Zara Opozishkakan, which is called Medical Terms, and about 30 lectures we gave it to our people to be aware of every point and every aspect of the thyroid surgery and how to guide them for the treatment and approaching them by the doctors and visiting on the annual basis. فالحمدلله يعني even post-operatively we are not leaving the patient. We have application and we are calling the patient back. We are taking a feedback. We are collecting all the complications. We have also for the thyroid, and we have a Geshbin group which is called FAL group for the all the breast cancer. We are gathering them. We are talking to them. And we have alhamdulillah on the 2 wings. We are following our cases and giving them every knowledge what they need. Barakallahu fikum.
شكرا. Thank you, Dr. Abdul Wahid. Well, if there is no more comments, I want to comment on a few things, if you allow me. Doctor.
Really, I want to talk about briefly about 2 practical points. The first one, the anesthesiologist who is sharing with you the operation room during thyroidectomy, and the position of the patient should be monitored well, as the neck extension, as good exposure for your surgery, number 1. Number 2, we are talking about implementation of the calcium and the vitamin D3 pre-operative for 2 weeks, which leading to improvement or preventing hypocalcemia post-operative. So please to put these points in mind.
Okay.
Thank you very much.
Thank you. Thank you. The first point I want to mention, Dr. Shko, well, on behalf of myself and others, I want to thank you in front of all for the nice organization of this event so far. I think this is one of the best events that I ever attended, and I knew that there's a leader after that, and thank you for this activity and for this organization. Thank you, Dr. Shko. Inshallah. Second, I will revisit again the nutrition topic. Nutrition is very important, actually, and I think we need to concentrate more next time on having a nutritionist with us to do our best to prevent as much as we can, or delay at least the diseases of thyroid disease. The second thing, when I was a medical student, about 18 years ago, we just visited thyroid topics briefly. If we were lucky enough to have a round with a doctor about thyroid, we will have the round. If not, we will have only 1 or 2 lectures in surgery and in medicine, and we might have a seminar. I think thyroid is an organ that needs to be involved more in teaching, and we need to improve the curriculums in our universities or institutions to concentrate more and focus more about thyroid diseases in all age groups as primary diagnosis or as a complication for other diseases. The last thing, I want to ask a question. Maybe pathologist will answer me about it. Do you know what is the most common diagnosis in the adjacent tissue of the lesions of the thyroid? So we have like a surgery for a thyroidectomy, for a papillary thyroid carcinoma or a follicular adenoma, multinodular goiter, whatever. This is the primary diagnosis. What we can see, what we do see in most of cases later, Doctor.
Palpation thyroiditis.
Palpation thyroiditis. This indicates how stressful is the life of a patient who is knowing that he or she is having a lesion in the thyroid, and we are telling him or her, wait for 3 months or 6 months, or we don't know, just wait. All day and night they will keep palpating the thyroid, and we will have most of the tissue adjacent to the lesion will have palpation thyroiditis. So thyroid diseases or having thyroid nodules is something very stressful for the patient, and we need to focus more in public awareness about these diseases, about how we can manage them, and about what we need to do in order to prevent the complications or prevent the stressful life or stressful wait for the patient. تفضل دكتور.
Thank you very much. I talk too much. Thank you very much. What I see in the primary care, when I do screening on thyroid function tests for adults, I see quite a lot of patients with subclinical hypothyroidism. where means that TFT is abnormal while patients totally asymptomatic. So this is the dilemma. So I don't know what to do personally. Sometimes I start them on levothyroxine 50 micrograms, bring them back after 3 months and repeat the test. And some other doctors suggest that just leave it and repeat the test. I don't know how is the protocol in this area. Thank you very much.
Anyone who can answer this? You mentioned that patient will have low results, clinical, without complications or without manifestations. So what to do? Any answer? Endocrinologist?
Subclinical hypothyroidism. So, if you have indication to give the thyroxine, we have in the pregnant lady. If you have the TSH above 10, if you have the features suggesting the hypothyroidism, you'll give the thyroxine. Otherwise, you should do just the follow-up.
Follow-up. Okay. Yes. Okay. Thank you, Doctor.
I'm sorry if I took more space than. I want to say that in Germany, in the kindergarten school, they will teach the kids to avoid fluoride in their toothpaste. No fluoride, because fluoride is found that one of the activating factor for thyroid disorders, for hypothyroidism, and even in the Hashimoto's thyroiditis. So dietary regulation and instruction better to be in the education because most of our disease start in early childhood. And avoid radiation. I'm sorry to say that even in this city there is no protection for the neck of the children for when they are taking chest x-ray. Previously in 70s, 80s in Baghdad, in the medical school, there was a cervical collar to protect, the lead collar to protect the thyroid gland. Now no one takes care. So the low dose of radiation to the chest should be avoided whatever, because this is the inducer for future carcinogenesis in thyroid. This is important. Personally, for your question, what's about the epidemiology of thyroid disease in the country? As a personal level, some of the students, they are senior now. We did study on the volume of thyroid gland according to the age groups. Preschool, school, intermediate, university school. The difference, how it changed according to the age. And also during pregnancies. There is an MSc, very good work. I was supervisor on the change of volume thyroid hormone during pregnancy, because pregnancy is very important and need a special attention for thyroid disorders, even subclinical hypothyroidism or thyroiditis, which occur in about 5% of all normal postpartum ladies, should be taken in consideration. And also the meeting in the TV in the area local, there is a lot of meeting on the instructions and information for the people in general to understand the importance of thyroid diseases. And also previously, not now, we have around to the school, primary school, intermediate school, to instruct them about the importance of thyroid diseases. Okay. Now it is now decreasing. Thank you very much.
Thank you. Okay, with this, we conclude the organizers wrote down all the comments that you mentioned during this session. We have this QR code that you can scan and add any comments on it, so we can discuss it later on and build upon it. I hope this meeting was fruitful for us, and I hope Dr. Abdul Wahid and the committee will approve the next meeting as soon as possible, so we start inviting you and hoping that we will meet you again next year, inshallah, in the second summit. Dr. Abdul Wahid?
Let's to ask the audience and to vote. I'm ready. I don't have any mind. Barakallah.
Okay. Yeah. Do you accept having the next summit in Amman, inshallah, next year? Okay. You are more than welcome, inshallah. Okay. Thank you very much.
Thank you, Dr. Muhammad. Really a wonderful speaker, wonderful chairman for that open discussion segment that we had. Our last comments will be by Dr. Shko himself. He will be discussing the smart subspecialty and the comments regarding it a little bit into that. Dr. Shko.
والله أنا لا ولا عود صوتي أوكي عفوا السلام عليكم كما يقول أهل العراق الله بالخير ألف مرة hundreds of times thousands of times just welcome to Smart Health Tower Sulaimani we just welcome not these 2 days every time everywhere you need us, we will be online. That's why we have defect in the emails and your phone numbers. Just please, everyone who has just not put it his phone number and email, even for the certification, just please took your phone number as emails in the reception. Every time when you think about the Middle East, as a part of your comments was mentioned here, was data, collecting of data. I'm sure that hundreds of, each of you as a radiologist, as a surgeon, as an endocrinologist, as a surgeon, you know the surgeons, seen hundreds of cases. But where's the data of these cases? Why not has been collected? Believe me, the best place for collecting your data is not a folder in your personalized computer. The best place is to have an official site for your work that you have been done. So briefly, I will tell you about what we have done about thyroid subspecialty in Smart Health Tower, about how we collected data, how we improve our publication, how we make a huge team composed of the surgeons, specialized nurse in thyroid care. Just remember this sentence. A nurse specializing in thyroid, not a subspecialty of a general surgeon. So briefly, I will show you the site. Just if the site coming to the screen. This is briefly the site of the first Middle East Thyroid Summit. Just please change it to maybe I get old. I cannot see the words. SST. Okay. Here's the official site of the summit that has been organized and arranged by thyroid team subspecialty. If you click here, so this is the official site of the thyroid team subspecialty, which composed of these outlines above. Even you can register the summit from here. Here is the team. Maybe you can watch this video together about the team. So they'll fix, my friends will fix it. Here's the team. Here's the experience of our team. All of the things has been written. Let's come into the publication. Just this year, we have almost about 37 papers which will be going to be published. Till now, 15 of them has been published internationally, just about the thyroid team. This is all the papers that has been published from our team. I will just show you some of the special papers that has not been done previously, that has been by us. This is the Google Scholar of Dr. Abdul Wahid, Muhammad Saleh, specialized in head and neck surgery, 1,184 citation. For the first time, we publish a paper. Usually, using mesh for the hernia in abdomen has been used previously. What about using the mesh in the faces? Can we get benefit from it? Let's see, this gentleman has a defect, ugly defect in the face that makes problem for him for years. Let's see the result. Smiling. Satisfied with the result. For the first time, mesh has been used in the face by our team. Let's see interested article again. Thyroid nodulectomy, you see it previously. Believe me, using thyroid nodulectomy for the malignant thyroid nodule is the first time used by the thyroid subspecialty in our team. Different type of removing thyroid in the neck. We have our special technique of removing thyroid, modified thyroidectomy, with the less side effects or complication of injury to the recurrent laryngeal nerve, hypocalcemia. This is a special technique. You can just see the Google Scholar, you can just read it and get benefit from it. And lastly, this is the Google Scholar of the hospital, Smart Health Tower. Just the last year, more than 92 papers has been published in the hospital. And the goal of this year is about 200 publications. So this is all of the things that I want just to share it with you, is if you want to make yourself as a major in your branch, even in the internist, surgery, radiology, you should have an official site for your team. And after this we have, for all the surgeons, we have a huge list of thyroid surgery, which will be, inshallah, we will go to the operation after lunch. About, I think, 33 cases is ready. 15 total thyroidectomy, 6 parotid surgery, 1 neck dissection, 2 to 3 flaps. All the cases ready. Anyone who want to join us in the operation theater, just please write your name in 14 floors, just to have a data about how to just divide the doctors in the operation theater. So this all was my talk, and a part of our side is not just reported. It's just to have an educational purpose about what you have previously been seeing. You see an interested cases, it's not a case report, but you want to share it with your colleagues from the other parts. So we have a part of our site written gallery. Every cases that we are seeing daily, just kindly please open one of them. Just let me just let it go. This is the BCC. Believe me, for the educational purpose, not even for the students, for every even subspecialty, they can't benefit from this album cases. Here's the image. Here's the case presentation. A 45 years old female till the end. Examination, what's written, ultrasound of the neck, management. I think it's a diagnosis of the oncocytic cyst lymphos, ruling out malignancy. This report is written by Dr. Ari, histopathologist. You can see the operation image with a high quality. If you collect about 20 cases for each year, just think about it, how many cases you will be collecting in the next 10 years. It's a purely educational. Everyone can visit the site to have any interest in the surgeries of the head and necks. It's not just composed of the thyroid, it's composed of the head and neck cases, parotid parts. And we have every activity of our team, it will be published here. Previously, we did a fast-track review about the thyroidology, about the hypothyroidism. It means fast-track review, it means you just select a topic, and in one day, you will review just this topic. Think about it, you have just one day about all the aspects of the hypothyroidism. Every guideline, every textbook will be reviewed. Lastly, let's see the statistics of our cases. Unbelievable. More than 12,000 cases has been operated by our team. How many years? 2016. Till now. It's a job of a team. والعون من الله. Uh, 6,500 total thyroidectomy, 1,500 lobectomy, neck dissection 800. Difficult operation, recurrent goiter. Only the surgeons will understand this. We did about 350 cases of the recurrent goiters. Almost half, or less than half of them, just was having one nerve. Alhamdulillah, all the operation has been successfully been done. Thyroglossal, thyroid cancer, even the prevalence of the PTC is the most common one. 1,850 follicular thyroid carcinoma, medullary thyroid carcinoma more than 60, and the screen is interrupted. That was the last thing that I wanted just to tell you about the statistics. At the end of my speech, all of this has been done بفضل رب العالمين وما توفيقي إلا بالله. Thank you.
Thank you, Dr. Shko, for kind of giving a summary of what we do here at Smart Health Tower and the Smart Subspecialty. We'd like to go ahead and conclude the second day. So our welcome and thanks to everybody. Really, really appreciate all of the doctors, all of the speakers taking their time out of the summer, coming here, answering our invitation to visit us in our lovely city and get to know each other better, and also try for the future for better events and bigger things, inshallah. Just a few short announcements. We'd like to thank Smart Health Tower, of course, for hosting us, and also our sponsors. They also were a big help in the organization and the onset of the event. Again, a very warm welcome. We do have a short. We do have a few announcements to make on what's going to happen after. So the conference will divide into two groups. One of the groups will be those doctors, those surgeons who want to visit. We'll have a clinic tour. We'll have a quick 10 to 15 minute clinic tour, which is on the G floor. And then afterwards we will have prayer and lunch. And then inshallah they will join us in the surgical ward on the 9th floor. For those doctors who will not be joining us in the surgery, buses have been prepared on the ground floor, which will take them to a small, I was going to say clinic, but it's a small camp, like a picnic outside of the city, in a place called Dokan Lake. So inshallah they will be visiting Dokan Lake for those doctors who are international and non-surgical, and also some of the other guests that we have from inside of Iraq. You are free to bring your own car if you have your own transportation, but also transportation is provided and lunch and accommodations are provided at the picnic site. For those doctors who will be joining us in surgery, we will go ahead and meet them downstairs and then reconvene after. At night we will go to the picnic location to meet the other group. I think the Smart Health Tower also wanted me to mention that there will be again a QR code on the screen. So this time, please feel free. We won't let you leave until you fill out the QR code and the feedback. And also for the doctors, we'd like to thank you again for being here with us. Inshallah, we'll go ahead and conclude it. I think I mentioned everything. We have a comment, question.
I think all members mentioned good suggestions about the making society and guidelines about the Middle East and so on. But more important than that, I think it's before we leave the hall, make a team to work and discuss these suggestions. At the beginning, I think each member represents their country. Otherwise, maybe these suggestions live with us. And thanks.
Inshallah, thank you. So on what Dr. Muhammad also mentioned, inshallah, we'll try to maintain contact with each other in the next few years, and also inshallah for the next summit. I mean, I'm happy, more than happy to accept his invitation, and I think on the behalf of our team, inshallah, we will accept his invitation in Jordan next year. We'd like to thank the senior doctors, Dr. Kakil, Dr. Ali, for also being here with us today and making it happen with Dr. Muhammad. And also our local speakers, thank you very much for being with us. We'll go ahead and concede for today, and see you guys soon, inshallah. We would like to take one group picture. If anybody wants to take, please report to the front for the group picture, inshallah. Jamaat, we'd like to have one more announcement regarding the lunch situation. The lunch will be provided for those surgeons who will be attending only. The others, inshallah, will have lunch in their picnic site. Also, the hotels are until 12 o'clock. Anybody who wishes to extend it, I think they can talk to the Smart Health Tower and they'll arrange the hotel situation if you guys decide to further extend it. And afterwards, after this picture, everybody will disperse and we'll be done, inshallah. بكرديكي أو برزاني كدينا نوع عملياته لقل معنا إن شاء الله أوان لنا نخون باقي كي لشويني دكان لرمبو كروشتن لبي إن شاء الله أوشتان أنهبت رسمك جرينو إن شاء الله كتايبي هني دستان خوش به